You know, we hear the term ADHD thrown around casually all the time, but actually diagnosing it, it is definitely not just checking a few boxes on a questionnaire. It really requires a clinician to step up and act as a full-blown medical detective. The clinical process behind diagnosing attention deficit hyperactivity disorder is this incredibly rigorous, totally fascinating investigation. So let's jump right into this explainer and break down exactly how they do it.
I want you to put yourself in the clinician's shoes for a second. When a patient walks in presenting with restlessness, emotional dysregulation, or just really poor focus, how do you know for sure what's causing it? Sure, these symptoms are incredibly disruptive. They wreck academic performance, mess with jobs, strain relationships. But the catch is, they are also the exact same symptoms shared by a whole host of other conditions.
And here is the wildest part of the whole thing. Despite ADHD being a globally recognized neurodevelopmental disorder, there is literally no simple biological test to confirm it. You can't just draw blood, take a urine sample, or order an MRI to get a definitive yes or no. In fact, systematic reviews have shown over and over that neuroimaging and EEGs just aren't accurate or consistent enough for diagnosis.
So, how do they figure it out? Well, Section 1, Gathering the Evidence.
Without a physical test, a clinician has to build a rock-solid case using strict observational criteria from the DSM-5 rulebook. They're trying to establish a baseline. For a diagnosis, a clinician needs to see at least 6 distinct symptoms of inattention or hyperactivity in kids, or 5 for adults, and these have to last for over 6 months. Crucially, and this is a big one, these symptoms can't just happen at school. They have to be present in at least 2 settings, like home and work, and they absolutely must interfere with the person's daily life. Plus, several of these symptoms had to be there before the age of 12.
Now, because a single perspective can be, well, pretty unreliable, the clinician gathers clues from multiple informants using standardized rating scales. Studies actually show that reliability between different observers is often just poor to moderate. A teacher might see a kid really struggling to focus in a quiet math class, while a parent sees a totally different behavior at the loud dinner table. Getting forms from parents, teachers, and the youth themselves ensures the clinician gets a complete 360-degree view of the patient's actual life.
Which brings us to Section 2, ruling out the imposters. This is the real meat of the investigation.
This is the absolute core of the medical detective's job, the differential diagnosis. They have to rule out imposters. For instance, if the distraction only happens during severe manic or depressive episodes, well, the suspect is a mood disorder, not ADHD. ADHD is neurodevelopmental, meaning the poor attention is generally constant. It's been there since childhood. If a patient only loses focus during distinct episodic emotional shifts, the clinician has to pivot the investigation towards something like bipolar disorder or major depression.
Or think about this, how do you tell the difference between physical hyperactivity and severe anxiety? The clinician has to dig for the root cause. Is it a physical need to move, or is it hypervigilance and sheer fear? Someone with an anxiety disorder or PTSD might look completely distracted or restless on the outside, but internally it's driven by rumination or mind blanking. The clinician really has to peel back the layers to understand the internal experience driving that surface behavior.
And what if the agitation only appears when a kid is asked to do math or reading? Well, actually, scratch the ADHD theory. It might be a specific learning disability frustrating them, rather than a global attention deficit. Context is literally everything here. If a student is perfectly attentive during a hands-on science experiment, but gets super disruptive the second they have to read aloud, the clinician has to consider that something like dyslexia might be the true culprit. Even purely physical conditions are in this suspect lineup. Take obstructive sleep apnea. It can cause daytime sleepiness that perfectly mimics ADHD inattention. In kids especially, severe sleepiness doesn't always look like yawning and rubbing their eyes. A lot of times, an exhausted child will just bounce off the walls with hyperactive behavior to keep themselves awake. That's exactly why clinicians are strongly advised to check for sleep problems before ever finalizing an ADHD diagnosis. Moving right along to Section 3, Context is everything.
To successfully weed out those imposters we just talked about, the clinician has to zero in on the exact context of the attention failure. Let's look at a subtle distinction. Poor persistence on a task is very different from the selective zoning out seen in conditions like cognitive disengagement syndrome. While ADHD involves a really broad difficulty in sustaining attention across the board, CDS looks more like a sluggish, highly specific inattention. It's the clinician's job to spot these incredibly nuanced differences.
And sometimes, ADHD doesn't look like distraction at all. Hyperfocus is an inability to break attention, which can honestly mimic the obsessions of entirely different disorders. Because ADHD stems from executive dysfunction, patients sometimes lack the inhibitory control to hit the brakes. They might obsessively focus on one single task, completely ignoring the world around them. To an untrained eye, it might look like autism or an addiction, but a skilled clinician recognizes it as a specific ADHD presentation.
Next up, Section 4. Identifying co-occurring conditions.
What happens when the clinician realizes they aren't looking at an imposter, but an accomplice? ADHD rarely travels alone. It frequently co-occurs with conditions like oppositional defiant disorder. Here, the doctor must separate accidental impulsivity from intentional hostility. Did a child fail to do their homework because they got impulsively distracted by a video game and genuinely forgot? That's ADHD. But if they're actively refusing to do it out of pure defiance, that points to ODD. The clinician has to carefully untangle these interwoven threads.
Similarly, the general fidgetiness of ADHD has to be distinguished from the specific tics of Tourette's or stereotypies in autism, even when a patient has both. A patient might be tapping their foot because of ADHD restlessness, while simultaneously exhibiting complex facial tics from Tourette's syndrome. The clinician literally has to map out every single physical movement to its proper neurological source.
Identifying these co-conspirators isn't just some academic exercise, it is absolutely vital. You cannot successfully treat someone if you just throw ADHD meds at them while completely ignoring a severe anxiety disorder operating in the background. The treatment plan, whether that involves stimulants, non-stimulants, or psychotherapy, has to be custom-tailored to the whole patient.
Which leads us to Section 5, reaching a clinical verdict. After gathering all those clues, analyzing the timelines, ruling out the imposters, and tagging the accomplices, the clinician finally reaches a verdict. Now, critics sometimes brush this off as a subjective diagnosis, but this meticulous process of behavior elimination is incredibly rigorous. The global medical consensus is that criticisms calling the diagnosis invalid just because there isn't a blood test are completely unfounded. It's a highly structured, culturally validated process that consistently predicts successful treatment outcomes.
But let's look ahead to the future for a second. Researchers are hunting for actual biomarkers, like phenylethylamine levels, that could one day take the guesswork right out of this lineup. Studies consistently show that urinary and blood plasma concentrations of certain compounds are notably lower in individuals with ADHD. In fact, common medications like amphetamines actually jumpstart the biosynthesis of this exact compound in patients who respond well to the treatment. It's a huge breakthrough area.
So until that science is perfectly dialed in, the clinician remains our ultimate medical detective. But it leaves us with a pretty massive question. If a simple blood test can one day separate ADHD from anxiety or a sleep disorder in a matter of minutes, what happens to the incredible art of the differential diagnosis? It's definitely a fascinating future to think about.